Okay, so my name's Rob Dragg. I'm from, as you just said, probably introduce myself again. So thanks for Alan for sort of giving an overview of the programme earlier on. So what I'm going to talk about is Salisbury's sort of traceability programme that we've gone on board in the last year. So we were selected as one of the 6 demonstrator sites for Scan for Safety. And what we've looked to do is try and really pull out the patient safety elements of it. So although there's other things, catalogue management, PEPOL, which are included as part of the programme, we really want to focus on patient safety. So hopefully I can give you a little bit of background to Salisbury, a little bit of background to work that we've done, and how could you take that into the other countries that you're from. So this is a little bit of background to where Salisbury is based in the UK. When I sent these slides across and was given an overview of what Salisbury do as part of their services, Claire from GS1 in the UK said you might want to point out where London is on this map. So it's not my separatist trying to separate north and south. Near Basingstoke and Reading is where London is, but I think the reference point I prefer is, if any of you have been to the UK, is Stonehenge. So you walk out the front of my hospital and Stonehenge is right outside the front door. It's exactly where we're based, next to Stonehenge. Clearly that is a joke for anybody who is listening, but not too many laughs. So for around 450 beds is the size of the hospital, so reasonably small compared to a lot in the NHS. Serve a local population of around 320,000, but sort of spreading out to around 3 million for our regional services. So we describe it as a hospital on steroids, which is what we would say in the UK. So we've got quite a few specialist services, so our expansion of what the services we cover is probably replicable across to other nations as well. So that's a little bit of a background to Salisbury. Anyone who knows me personally or speaks to me for more than 5 minutes will understand that I'm quite a passionate runner. So running is something that I do. I was out there this morning enjoying Berlin, and I will be later on again this afternoon. So I wanted to play a video. Sorry, yeah. Apologies. All right. I wanted to play a video. So if I tell you that's a race I'd like to do one day, you're probably going to look at me a bit strange and say, why would anyone want to do that? So what relevance has that got to healthcare? So there's a race in a desert. I think Alan gave an overview earlier on to say the NHS and probably healthcare in general is at a place where it's massively challenged. And I won't highlight this point too much because he went through the numbers in a big detail. It's not just a race in a place which is challenging. It's done in July, the most challenging time of the summer. So why would you pick to do a race at that time? It's not helped by the fact that 135 miles is a long way to run, but actually, while I'm talking, Usain Bolt can run the 100 metres in 9.58 seconds. We'll spend £10,000 on preventable disorders such as diabetes and heart disorders. So we've got this combination of conditions which are making healthcare very challenging. So something's got to change. So I was asked to present on patient safety. My background was originally in a procurement one, and what we're doing as the demonstrator site is place, product, process, and patient. And I would say in the past in the NHS, we've always had the best of intentions, and I think this was an example on the right-hand side, which I'll go through in a little bit more detail. So the process element was always the thing we've tried to get right, but without technology, it's really difficult. So this was a sign, and I'll read it out. It was above the orthopaedic store, so orthopaedic products, thousands of them in our store. Please make sure that they're in date before you leave the store. Sounds a fantastic sign to have up. How often are people going to be able to check those products visually before they leave? You might be picking up 10, 15, 20 products. The patient wristband. 2008, it was mandated in the UK that you would have a printed wristband. We did that as part of the requirement. We didn't actually scan it for any means possible at all. So it was a fantastic example of you've got the technology there, but you don't use it. So what we started to do as part of this programme, and obviously we're funded to do so, is to start to build these together. So error is human. If you haven't got technology to assist you, mistakes will be made. So what we concentrated on is making sure we can scan within our systems, not at every single point. So when you start to say to nurses you're going to have to scan, are they going to have to scan every 5 minutes, every 5 seconds? Well, no, just where it adds value. Positively IDing the patient at the bedside and uploading that information directly into our EPR. So an example of that was in our patient observations tool. So previously it was on paper, and we had a system that we were tech funded by the NHS to build, which is called POET, Patient Observation Tool. Previously they would go in to do patient observations, maybe 5 minutes, 10 minutes. They would pick from a list. So they would be on a ward, busy ward, get a list of the patients who you could take obs for, and you would click on them. 2 o'clock in the morning when you're taking obs for a patient, potentially you could misassign them, give them the wrong obs, and change the way that patient is treated based on their score. We've changed the application now, so you would just scan the wristband, it takes you straight to the patient. I'd just point out that isn't a real patient wristband. I did get a phone call late Friday to say, just wanted to make sure your presentation hasn't got live patient data on it. This is Ravi is our test patient, or Ultra Ravi, he's been renamed now. Not at my request, but I quite like that because I'm a bit of an ultra runner myself, as you'll see from the start. Other applications which exist in the hospital, and I think the biggest challenge is the fact that there's so many applications. The ones that we focused on initially are ones that are easy to change. So our blood monitoring system, I think somebody said earlier on, that is being used to scan the wristband. That is now. The real critical bit, I think, and Alan from North Tees, they're doing great work on this, is the event capture data. So rather than focusing on product specifically, catheters and cannulas was something that our nursing staff said, if I could have anything to do with catheter and cannula, when they're put in, what is the site like, if I could scan myself, if I could scan the patient, if I could scan the wristband, and I could know a timestamp of when that intervention happened, I can make a different clinical decision at a later date because of it. So that's something we're looking on to build, and more it will be away from product actually to replenish, more product and event capture data. Our CRIS radiology system is something that you get booked onto to have a scan, CT or MRI. That will be changed at the end of April to scan the wristband before you have a CT scan to confirm what area you're going to have scanned. Is it your head? Is it your arm? Are we going to do the correct scan? Are you even due on for a scan? I was sat in a meeting probably 2 or 3 weeks ago, and a couple of people looked at me strangely when I said that this was a thing we needed to do. Our director of nursing actually opened up and said, no, this is something that happens on a reasonably, not regular, but will happen within time. So the future learnings probably from ourselves is really that clinical engagement, and I think the bit our focus on at the end is we've seen an absolute sea change with the naming of the programme and with clinical involvement. So my executive lead is our finance director. I don't actually see our finance director terribly often anymore. It's our director of nursing that I see time and again with this. So although he is in name the executive lead, our director of nursing is the one pushing and driving this. And I think she's speaking at a future conference as well, which I was told earlier on this week I'm the warm-up act for. So hopefully she'll do a better job at slowing down a little bit to start off with. Probably the best example that we got this week was when we were in orthopaedics. So we've been in the store all weekend counting products. So those barcodes that were put up that are lot numbers, Hibics, I spent hours of my weekend and my life I'll never get back scanning those and having a lot number scanned instead of a product barcode at the weekend. So orthopaedic staff have started to scan within the procedure. So Monday morning, one of our orthopaedic consultants, in a rush, got a lot of procedures on the list and said, I don't need to scan them before the procedure. My team always check. So my colleague was in there, who's our benefits and change lead, Marie. She started to scan them during the case instead of the member of staff who was going to do it. And so be it. The first case we did, one of them was out of date. And she actually said before they used it, this is actually out of date. They thought they checked them, they hadn't. Surprisingly, when he went to get the next 2 implants, he asked, can you scan these before you use them? So what is the risk that those products get used? So what's on the shelf? We didn't have any visibility in Salisbury previously before we scanned everything in, so you're looking at expiry dates that may exist on the shelf or not. So 10,000 products we counted, so 4,000, this is the individual boxes, so you've got 10,000 things sat on the shelf basically. And what do we find that was out of date? So that's that same sign in the top right-hand corner. Next to all the boxes of out-of-date product that were in that store. So obviously, clearly, something was going awry. So 6% of what we found on the shelf was out of date as of last weekend. Another 1% went out of date the end of this week, so the end of March, and then another will go out of date in the next 6 months. So realistically, there was probably an 8 to 10% risk of product on the shelf that were expired. So I think this is something that we would find again. We found it in cardiology, we found it in other areas. So I would say that most people, if they don't understand their wastage, that is existing in most people's supply chain. So now we scan that information in. This is from one of our inventory systems. This is from cardiology. So we start to get that real data that moves and changes as product is received into the system around what is our predicted wastage for the next 6 months. So we can work with providers, work with local trusts, potentially work with other providers to swap that out and hopefully both protect the patient and reduce the amount of wastage in the supply chain, because as Alan said earlier on, it's a combination of both things that makes this program work. It's not purely about cost savings, it's not purely about patient safety. They both live in harmony together. So although supply chain efficiency and savings is probably a dirty word in some people's mind because clinical staff see savings as reducing maybe the people they've got in front of them, I think this is one programme we've seen that the amount of time they spend wasting finding products and equipment is huge. And so we're starting to hand all of that is handed back. So in cardiology, we had band 8A nurses, senior nurses ordering product, which they now no longer do. The big one, I think, is medical equipment. So I'll come on to an example for that one. If only I knew where it was. There's been quite a lot of debate in the demonstrator sites and probably wider about what is the use of a GLN in the future. If I'm honest, I don't think we know all the use cases now. They are the building blocks. But I'll give you a couple of examples which we're looking to solve. So this was a broadcast sent out to 2,000 members of staff in our trust, and we get these quite regularly, so I'm keeping them, saying, could someone find this Doppler probe and return it because it's needed in Theatre 10 for surgery? I mean, needle in a haystack, I wouldn't even know what it looked like and where it was going to be to start off with. Once these GLNs are built into our systems, you could find something in a room on a CAD drawing exactly where that item is located. Nurses can actually get on with their job rather than sending emails to the entire area. The other one, so if we've got all these location numbers mapped onto the hospital site, what sort of questions can we start to ask? I was walking down the corridor with Lorna, our Director of Nursing, and she introduced me to the new Head of Risk. And she actually, it was probably one of my proudest moments in the last week where she said, Rob used to be in procurement. He's now more on the clinical side, which I think because of this programme, we're now focusing on less about supply chain, more about patient safety. But one question she asked is, could we use those GLNs to start to record where those falls happened? Is there a recurring pattern? Is there an area within the hospital which is of high risk that we need to change the way our buildings are designed to reduce those falls? So although unrelated to supply chain, patient safety is something that we'll start to build off of those areas. Really the bit that's most important from when we were designing patient safety is probably the top two. So the people are always going to be the critical factor, and I think there's a building momentum of using those GS1 standards. I love the example earlier on that said the value of a standard is the amount that people actually use it. So I think that for me would be an example going back to Parkrun. So Parkrun was a UK phenomenon started at Bushy Park with 6 people running. Now it's a worldwide free event, 5K run that's spread across multiple countries. I think GS1 standards are similar. They should be used for the value of the patient and should just be exported everywhere. The process clearly is probably the critical part of this, where it moulds the two together. Unless we get away from manual checks and people not really seeing the benefit to it, it will never change. And the final part that we put in place is the technology. So the technology is overlaid at the end date. At the moment, I would say we're still using technologies which need to change. But a phrase that was said to me a couple of months ago that I really like is, don't let perfect get in the way of better. So people are waiting all the time to sort of say, oh, is the technology right? Are the standards developed enough? Well, if we don't get on that journey and start to use them, then they won't deliver and they won't be perfect. The support team is probably the critical part as well. So this was a charter that went in the front of our business case to the Department of Health to say that when we were signed off. So all of our board members, and some of these have changed now, signed up to say they see the value of GS1 standards and they want to carry on using them going forward. And I think those are the people you'll need along the way. Coming back to the video at the start, it's going to be a long journey and there's going to be changes on the way, but I do feel that actually patient safety is the thing that drives this, and we have seen an absolute sea change over the last few years. So I'll take any questions now. So thank you.